Balavaskar sir has come, Sri Ganesh.
Okay.
Sri Ganesh sir, yes, good to go.
Yeah. Can you just make Balavaskar also co-host? I can't find him. Okay. Good evening, everyone, and welcome to the 10th episode of our ISA Karnataka monthly academic program. And as usual, the format is we have the first talk for the postgraduates and the second talk for the practitioners. And we have two young but dynamic anesthesiologists who will be discussing two important but diverse topics, and two experienced and very senior anesthesiologists to moderate this session. Before that, I will just like to share one slide and okay. I am not able to share, Allah.
ಇಲ್ಲ ಸರ್, ಏನು ಶೇರ್ ಆಗಿಲ್ಲ ಇನ್ನು.
Just one second.
Yeah.
Just one second. Okay, I'm not able to do that. At the outset, I will welcome.
Mail ಮಾಡ್ತೀರಾ ನಂಗೆ?
Okay, I will just WhatsApp you can share it. Okay, fine.
Okay,
so we have our President Dr. Vijayanand sir, Vice President Dr. Shukumar Kumbar sir, Balbasa sir, ISA National Past President and Academic Coordinator for our program, along with Gurudat sir, who is also the chairperson of our academic program. Welcome to you all, and also to all the participants. I can see about 58 people are logged in. Welcome to you all. At the outset, I request Vijayanand sir, our President, to make the opening remarks, and then I'll take you through the program. Vijayanand sir.
Yeah. Good evening, Vice President, Secretary, Executive Committee members of the Indian Society of Anesthesia Karnataka chapter, that President, Past President, and Academic Chairman Dr. Balavaskar, the Academic Coordinator Dr. Gurudat sir, the two speakers for today, Dr. Azam and Dr. Jagdish from Bhagwan's Mahavir Jain Hospital, Bangalore. The two chairpersons, our beloved past President of India, the Kuchala Babu from ISAKA. So welcome you, and Dr. Jairam Rai from Puttur. I welcome all the participants of this 10th academic event of ISA Karnataka. We were unable to do it last time, but I'm very grateful and thankful to Dr. Balavaskar, who brought the speakers in this month, because in spite of the very busy schedules of all the anesthesiologists in Bangalore and Karnataka, we were able to do the last month. So we apologize for that. And I thank Dr. Balavaskar sir for making this occasion so that the program is continued month after month. Thank you, sir, Balavaskar sir. I welcome all the people for these wonderful topics today from the Sri Bhagwan Mahavir Jain. Thank you. Sri Ganesh, please proceed the meeting.
Yeah. Thank you, sir, President sir, for the opening remarks. I now request Balbasa sir to make his opening remarks. He's the academic coordinator for our programs.
Yeah, good evening. Very happy to have a session after a break due to unavoidable reasons the last month. Dr. Vijayanand, the President of our ISA Karnataka State Branch. Then we have got Vice President Dr. Shukumar, Dynamic Secretary Sri Ganesh, then of course all committee members, and Dr. Gurudat sir, he is our scientific advisor for our Karnataka State Association, and two distinguished senior most and experienced persons as chairpersons. I thank Dr. Kuchala Babu sir for having accepted to be there for today's program, sir. Thank you very much. And also for sir, Jairam Rai sir, thank you for accepting and being here for today's program. and two very dynamic speakers, because they have been doing this for the last few years. Dr. Azam, who is very good in conveying important technology-related aspects related to anesthesia. Also, he has been very good. Thank you for joining. And Dr. Jagdish, very happy that we have got two of you from Jain Hospital, and Dr. Sudhakar Koppad has been very considerate when I discussed with him about 2 months ago. So thank you, sir, for the participation. And I wish the program all the success. And again, once again, congratulations to ISAKA Karnataka. Thank you very much. Thank you.
Thank you, sir.
Thank you, sir. I'll just share the screen once. Is my screen visible now?
Yes.
Yes,
Yeah.
yes.
I'm sure some of them will be able to identify. We lost this gentleman recently. He has made significant contribution to our specialty. We'll come to that later. And with this, I now request our moderators, Kuchala Babu sir. He is the past ISA National President, Academic Coordinator, and very senior practitioners in Visakhapatnam. Welcome to you, sir. And also Jairam sir, he is also a senior anesthesiologist. Both of them will moderate this session. And I request the first speaker, Jagdish, to please put the first slide, which contains your CV, brief CV, so that our moderators can introduce you, and then we can proceed. Kuchal Babu sir, your opening remarks, and then we can start the session, sir.
Yeah. Good evening, all of you. Especially thanks, Dr. Balabhaskar, to invite me for this today's wonderful program, chairing for the session. As I say, Karnataka is doing an excellent job, especially doing a good academic programs, even though in a lockdown and during COVID time also. Today's topic, Dr. Jagdish, from consultant anesthesiologist from Jain Hospital, Bangalore, is a good topic for especially the postgraduates and the practicing anesthesiologists. Anatomy, especially for the postgraduates, anatomy of the brachial plexus and the variation, that is the most important. And most of them are well versed about the anatomy. The variations is the most important. What the reason is, a landmark technique and the nerve stimulator is a very easy, very difficult. Sometimes in a variation of the anatomy, we may miss some blocks, especially some sparing effects are more common. That's why most important, ultrasound will pick up and we can give a good block. That what I hope Dr. Jagdish will enlighten us anatomy and the variation of the brachial plexus. Thank you once again for giving the opportunity.
Dr. Jagdish, you can start.
Good evening, one and all. Firstly, I would like to thank the ISC Karnataka chapter for giving us this opportunity to share our knowledge on upper limb regional anesthesia. Secondly, I would like to thank my department for choosing me to present this topic in front of an august audience. The image what we see in the first slide is the 3D MRI reconstructed image of the brachial plexus. So I bring greetings from hospital, my place of worship. It's a 450-bedded tertiary care center with flagship department like vascular surgery, which has given us ample opportunities to practice regional anesthesia. On the outline, we are going to talk of the anatomy of brachial plexus, the anatomy of its terminal branches in the arm, forearm, hand. Brief thing on the microanatomy of brachial plexus and nerves, the variations in anatomy and of brachial plexus. I hope all of us recognize him. He is the former president of the US, John F. Kennedy, who once said that in a crisis, we better be aware of danger, but we always have to recognize the opportunity. So the crisis which we are in is COVID-19. The danger is supplementing these patients with general anesthesia. The most important opportunity that we have to recognize, as quoted in this journal, which was published in May 2020, says finally, at last, the regional anesthesia has become the first choice during COVID-19. So with this outset, we are going to talk about brachial plexus and its anatomy and variations. The embryology of brachial plexus, we have noted that by 4th week from the primordia of the arm muscles, the nerve roots emerge. By day 32, there are extensions from C5 to T1. By day 33, the nerves merge to form brachial plexus. By day 50, we already have an orientation of adult brachial plexus, which is formed. Coming to the gross anatomy of brachial plexus, it arises from the ventral rami of C5, C6, C7, C8, and the T1 nerve roots. So they emerge as roots. They form trunks over here, and then they divide into anterior and posterior divisions, and then form cords and end as terminal branches. As we can see how it is wound around the axillary artery as it flows into the arm. The brief anatomy of its divisions are the C5, C6, C7, C8, and T1 nerve roots, which goes further. The C5 and C6 together form the superior trunk, the C7 forms the middle trunk, and the C8 and T1 forms the inferior trunk. These trunks divide into anterior and posterior divisions respectively, and then form cords. So the posterior divisions of all these plexus, all these divisions form together as a posterior cord, whereas the anterior division of the superior trunk and the middle trunk form the lateral cord, whereas the anterior cord of the division of the inferior trunk forms the medial cord. So these cords end up finally giving the terminal nerves. So how do we see the gross anatomy? We can see the nerve roots coming out from the spinal cord through the foramen and the ventral rami flowing down in between the two scalene muscles, forming 5 ventral roots, forming 3 trunks, and there are 6 divisions with 3 anterior and 3 posterior, which passes behind the clavicle in the supraclavicular area, descending into the infraclavicular, and then flows through the axilla to the upper limb, thereby supplying the whole of upper limb. Coming to the recap of this brachial plexus anatomy, we know these are the roots from C5 to T1, which forms trunks, the upper, middle, and the lower, and then which forms division, forming the anterior and posterior division, which forms cords, as I said, the lateral cord from the anterior divisions of the upper and middle, the posterior cord forming from all the posterior divisions, and the anterior cord of the lower trunk forming the medial cord. And these ends as the terminal branches like radial nerve from the posterior cord, the ulnar nerve from the medial cord, the median nerve from the lateral and the medial cord, musculocutaneous nerve from the lateral cord, and the axillary nerve, which is a branch of the posterior cord. So when we are asked to write an anatomy of brachial plexus on an exam paper, this is most easiest to write, as we have found. We can initially note that we are naming all the 5 nerve roots, and we are naming each branch over here. So the nerve roots give rise to dorsal scapular nerve and the long thoracic nerve. There is a small contribution to phrenic nerve in around 75% of patients. Whereas in the trunk area, there are 2 nerves, that is suprascapular nerve and the nerve to subclavius. In the level of divisions, we don't find any branches being given out. Whereas in the cords, the lateral cord gives rise to the lateral pectoral nerve, and the medial cord gives rise to the medial pectoral nerve, and the medial and medial cutaneous nerve of arm and forearm. Whereas the posterior cord gives rise to a posterior superior and inferior subscapular nerve, the thoracodorsal nerve, and the axillary nerve. Whereas the terminal branches are namely musculocutaneous, the median, the radial, and the ulnar nerve. Coming to the motor innervation of the brachial plexus, which is more important when we are using peripheral nerve stimulator. The nerves which are arising from the trunks, the nerve roots, are basically supplying the muscles of the chest and the back, namely the lateral pectoral nerve supplying the pectoralis major, dorsal scapular nerve supplying the rhomboids, the upper subscapular and the lower subscapular supplying the subscapularis muscle. The most important, the axillary nerve, is going to supply the deltoid muscle. So the medial pectoral nerve again supplies the pectoralis major and minor. Coming to the terminal nerves, the musculocutaneous nerve is the nerve of the flexor compartment of the arm. It supplies the coracobrachialis and biceps brachii and brachialis. whereas the median nerve supplies the muscles of the forearm, that is the digitorum superficialis, the pronator teres, and the flexor carpi ulnaris. The two branches which comes from the lateral and the medial cord supplies all the muscles of the forearm. The radial nerve is the predominant nerve which supplies the extensor compartment of the arm, which supplies the triceps, brachioradialis, and the extensors of the forearm also. The ulnar nerve is the predominant nerve of the hand, where it supplies all the interossei muscles and the medial two lumbricals, except that it supplies most of the muscles of the hypothenar eminence. So when we are planning to give a brachial plexus block, we need to know its motor function and the sensory function mainly to provide good analgesia. The most important thing which I would like to highlight over here is the supraclavicular nerve, which is supplying the most upper part of the shoulder joint. So which is usually avoided if we have not given a superficial cervical plexus block, that it is spared, and we can see no pain in this area if you have not covered that. And the intercostobrachial nerve, which is supplying the medial most part of the axilla and the arm. So these two are the nerves which we need to supplement when we are planning for any surgery, be in the upper arm, mainly involving the shoulder joint. So as we come posteriorly, we can note the medial cutaneous nerve of arm, the forearm, everything supplying over here and here. Posterior cutaneous nerve of the arm being supplied from the radial nerve is also predominantly seen over here. As we come to this slide, I would like to highlight that targeted nerve blocks are the fashion of the season. This is mainly important to avoid excessive nerve blocks to unwanted nerves which are not involved. Say if there is a cut lacerated wound in this area, we need to focus more on median nerve. So this is what is more important, be it for postgraduates, to realize what is the importance of knowing the sensory distribution of the arm and forearm. The medial 1.5 is supplied by the ulnar nerve. The lateral 3.5 is supplied by the median nerve. Whereas when we go posteriorly, it is predominantly the superficial branch of the radial nerve. And as we all know, the ring finger and the tip is supplied by all the three nerves. And the ulnar nerve supplying most of the dorsal part of the medial part of the hand. Why are we concerned about the microanatomy of brachial plexus? As we can see, these are the various cut sections at C5, C6, and C7. But once, as we see the slide, we can make out that the microanatomy is not the same at C5, C6, C7, and C8. It has been clearly noted that brachial plexus, though it looks simpler as we write as in a diagram, when we get into the depth, be it in microanatomy, it is not so simple. Each nerve root forms fascicles into itself, and we can see the small interfascicular connections. So these are forming plexus within plexus. So this is what is very important that we need to know. And we can see the dural sac, which is over here and continues as fascia around the brachial plexus, including into the axillary area. So as we come into the interscalene area, we can make out how the C7 nerve root is looking, whereas compared to the C5 and C6. And when we are looking into the supraclavicular area, when we take out this part and highlight it, we can see this is the intercluster area, which is more commonly referred to as of late for intercluster block when we are giving superficial, so supraclavicular brachial plexus block. And when we take each fascicle, we can see how distinct it is in forming, and there are how the amount of connective tissue that is present in this particular area. One thing which we need to remember is when we are performing an interscalene block, it is mostly the roots and the trunk which is involved. Whereas when we are giving a supraclavicular block, it is mostly the divisions. The moment we get into the infraclavicular area, it is the cords. And whereas when we are planning to give an axillary nerve block, it is no more plexus. It is already terminated into terminal nerves. So when we are giving anything inside the axilla, it is the block given to the terminal nerves. So a brief look into the gross anatomy in the interscalene area. As the brachial plexus descends in between the medial scalene and the anterior scalene muscle, we can see the brachial plexus descending down, and we can see how closely the phrenic nerve is traveling. This is more important when we are giving an interscalene nerve block, especially in patients who are having a respiratory compromise. And in 30% of patients, we can see the transverse cervical artery flowing in this area. So being aware of all these anatomical structures becomes very, very important when we are planning to give a brachial plexus block. So here we can see the needle coming down when we are planning to give a interscalene nerve block. The most important that I would like to highlight here is the presence of the long thoracic nerve, which is seen in the substance of the middle scalene muscle. So there are multiple literature which says try to avoid entering into the medial scalene muscle or use peripheral nerve stimulator to elicit the presence of lateral long thoracic nerve, because there have been multiple issues when the nerve has got severed and led into winging of scapulae. The second most important thing that I would like to highlight is the presence of vertebral artery. In case if you don't recognize this, the inadvertent injection into the vertebral artery becomes very, very common, and the patient will have immediate cerebral toxicity as it flows directly into the brain. So the most important thing I would like to highlight is the presence of this longus colli muscle. The importance of this is the presence of the cervical sympathetic chain in this area. So when we are depositing the drug in this interscalene area, the drug just flows down and can enter into this area, causing Horner syndrome. So when we are planning a brachial plexus block above the clavicle, we need to realize the presence of the phrenic nerve and the vertebral artery. I would like to emphasize in this place. So the most important thing is how do we reduce phrenic nerve involvement is by, there are multiple literature out of which one is giving an extrafacial injection when we are using an ultrasound, because it is found to have reduced respiratory complications as seen in this particular study by N. Palhais et al. In 2017. Coming to the brachial plexus in the supraclavicular fossa, which is most commonly done and practiced when we are as postgraduates and even in peripheral centers. It is also called as the spinal of upper limb, though in true sense it is not. The presence of the brachial plexus over here below the clavicle entering above on the top of the surface of the first rib, which is placed laterally and superiorly to the subclavian artery. So when we are planning for a landmark guided, we have been classically being taught that we are going to hit the first rib and walk over it, elicit paresthesia and inject. So we always have to remember that this is the orientation which is being given. If at all we are getting a vascular puncture from the subclavian artery, it is quite clear that our needle has to be a little more lateral and superiorly. So the most important thing which we need to remember over is this is the place of dome of the pleura. So the presence of pneumothorax is quite common. If at all we are not aspirating and eliciting any pleural puncture. The green colored structure which is seen over here is, as I said, the dural thing which forms the sheath around the brachial plexus over here. So the presence of sheath and the injection of the drug inside the sheath, it results in faster onset. So as we can see, the silver colored border which is there is the sheath which is around the brachial plexus in the supraclavicular area, where the drug is being deposited inside the sheath. We can see the presence of transverse cervical artery, the presence of subclavian artery in the medial side, and look how close the pleura is towards the brachial plexus when we are approaching in the supraclavicular area. So time and again, we would like to emphasize that presence of air inside the syringe on aspiration has to be dealt very seriously. So as I said, there have been randomized comparison trials between extrafacial and subfacial injections, which has shown in this particular study in 2015 that the subfacial injection leads to faster onset. But there have been studies where the amount of damage that it can do to the brachial plexus is also not to be ruled out. Here we can see the presence of pleura in very close proximity to the brachial plexus, which is around here. And though the recent literature have shown reduced incidence of pneumothorax due to the presence of ultrasound, but there have been many literatures which says it is non-existent. It's not non-existent. There have been multiple literatures which says the presence of pneumothorax, late pneumothorax, even occurring after 24 hours. Coming to the infraclavicular area, we are looking into the two places. One is the medial infraclavicular fossa and the lateral infraclavicular fossa, where we can approach the brachial plexus. The medial infraclavicular fossa, also fondly called as costoclavicular space. The most important thing that we like to see over here is the presence of the cords in one single pocket. So this makes it more easier compared to the lateral infraclavicular block, where the spatial arrangement of the brachial plexus differs. And we can see the distance is quite far off from the pleura to this particular area. So the chances of having pneumothorax in infraclavicular plexus blocks are quite reduced compared to supraclavicular area. So as in this particular diagram, we can see how it is placed in one single place, adjacent to the lateral axillary artery lateral to it. And as I said, the costoclavicular space where it shows in one conglomerate. The only thing we would like to emphasize over here is when we are planning to give a costoclavicular block, please be aware of the cephalic vein. And this is a particular thing to avoid this area while we are doing needling. Whereas as we pass down into the lateral infraclavicular space, there is thoracoacromial artery, which arises and enters between the pectoralis major and minor, and the spatial arrangement of the nerves also changes. As I said, even the pleura is quite far off, even in the pericoracoid space, where the plexus is found over here. As I said, the sheath continues into the axillary area, and this is the common arrangement which we can see in the axillary area, the median nerve superolaterally, the radial nerve being posterior to the artery, and the ulnar nerve always most of the times in between axillary artery and the vein, and the musculocutaneous nerve in the substance of coracobrachialis. Again, this is the pictorial representation of the same. The most important that I would like to emphasize over here is, as we give any blocks starting from interscalene to the axillary for our practice, we encounter a lot of blocks where it is not working. So we practice something called rescue blocks just to overcome and tide over the situation. If at all we are planning any rescue blocks, it is very imperative on us to know what is the upper arm anatomy of the nerves. As we can notice over here, the median nerve, which flows laterally, flows over the axillary artery and then the brachial artery in the anterior position, and then comes to the medial side. Whereas the radial nerve flows into the spiral groove and then comes laterally to flow in as superficial and deeper branch. Whereas the ulnar nerve maintains its medial course all through and comes behind the medial epicondyle and comes down. One more important thing about the ulnar nerve is it pierces a muscular septum over here in the upper and middle 1/3 of the arm, where it is in a very tight compartment. Avoid giving nerve blocks in this area and behind the medial epicondyle if at all we are planning any rescue blocks. As we enter the forearm, we can recognize the median nerve is in the medial position to the brachial artery. And as it flows down, it becomes submerged in between the superficial and the deeper muscle branches, and again becomes superficial in this to flow below the flexor retinaculum. And it forms, this is the area where there is carpal tunnel syndrome. So avoid injecting into this area when we are practicing a rescue block. The most important thing about axillary and suprascapular nerve is it is being mentioned as phrenic nerve sparing blocks for shoulder surgeries. As it is being taken off from the infraclavicular area, it enters and winds around the surgical neck of the humerus, and the suprascapular nerve enters from below the homohyoid and enters into the supraspinatus fossa below the supraspinatus muscle. As we can see, the axillary nerve winding around the surgical neck of humerus. Coming to the variations in brachial plexus, why it is very important to know, as mentioned by our moderator, Dr. Kuchela Babu sir, it is very important to know this for our block success. And it is very important to know to prevent any complications. And as said, rightly said by sir, it proclaims the importance of block aiding tools like PNS or ultrasound. There have been multiple variations which are seen in brachial plexus. As we go into this particular journal called Journal of Brachial Plexus and Peripheral, now there are umpteen number of journals regarding the variations. But why does this occur? It is because of the abnormal neuronal growth cone formation in fetal life, and most of the times this is the main reason due to the neurotransmitters during the growth formation. One thing which is very important to notice is there have been intra-individual variations between the right limb and the left limb in the same patients in 61% of individuals. So this becomes very important to know what about the variations when they are practicing brachial plexus blocks. When we go into a particular journal in Anesthesia Tutorial of the Week, which was published in 2017, to conglomerate all these findings, there have been 7 configurations of brachial plexus which have been noted. And these are described in the particular table. And most importantly, what we need to know is what is prefixed. Prefixed is the nerve root from the C4 also joining and giving rise to brachial plexus in the forming the upper trunk, which is seen in 17.5% of patients. Whereas when we look into postfixed, it is arising from the T2 space and T2 nerve root, and it is supplying the lower trunk. So this is seen in 7.5% of patients. The most important thing is it is very difficult to identify this even under ultrasound. The variations in interscalene area is also being seen. And the most importantly, as I said, the anterior scale, the medial scalene muscle carries the long thoracic nerve, whereas the anterior scalene muscle, we have seen around 25% of patients having the 5th nerve root. So please be careful before entering any scalene muscle when we are practicing interscalene nerve block. There are variations in the truncal level, where in this particular thing, we can see the upper trunk piercing through the anterior scalene muscle. This is the anterior scalene, which has been dissected, and the upper trunk piercing the anterior scalene muscle. And there is lower trunk, whereas we don't find a middle trunk, which is seen in around 13 to 35% of patients. As I said, the accessory phrenic nerve is seen in around 75% of patients. Whereas, is there a sheath? Yes, there is a sheath, as I depicted in the previous slides. We can find that there have been no upper trunk in around 1%, and there will be absence of inferior trunk in around 9%. The variations in truncal levels again persist, where the C5 nerve root divides into the anterior and posterior divisions, and together form the posterior superior trunk and the anterior superior trunk, as rightly pointed out here. And what is this, which is being laid out on a harrow mark, is the dorsal scapular artery. The transverse cervical artery is seen in around 30% of patients, as it is depicted over here. This study in 1958 says that around 30% of patients will have transverse cervical artery, whereas dorsal scapular artery is seen in 33 to 34% of patients. So we are seeing so many variations of vascular areas in this particular supraclavicular and interscalene area. Does it cause an advantage to a costoclavicular approach, or is things underreported? Apart from cephalic vein that we can see, we don't see any other vascular structures over here. So this forms one of the bases when we are having multiple problems with vascular structures. Again, the division level, there are around 33 to 33.6% of variations seen, out of which 85% of variations have been seen as the nerves are taking an origin from the anterior division of the middle trunk. So this becomes very important that we note over here. And the variations which are seen at the cord level, we can see this is the musculocutaneous nerve, and this is the median nerve. And we can see the variation where there is a interconnection between the median nerve and the musculocutaneous. As I said, the axillary nerve, axillary level, there are multiple variations. As I can go back to the next slide, where we see 64% of variation commonly seen as median nerve superolaterally, and the ulnar nerve between the artery and the vein, and the radial nerve on the conjoint tendon below. Whereas around 5.2% of patients, we see the median nerve and the musculocutaneous nerve together. Whereas in 5.2% of patients, we see the ulnar nerve and the radial nerve together inferiorly. Whereas we can see 4.5% of patients having all the 3 nerves in one single corner between the artery and the vein. And again, the musculocutaneous nerve and the median and ulnar, all 3 forming a single conglomerate inferiorly to the axillary artery in 0.7% of patients. The musculocutaneous nerve itself has various variations depending on its origin, as depicted in this particular article, which is again divided into 5 groups. So this is the amount of variations that we can see in each nerve level. All I would like to say is there are plenty of variations distally, and always we need to tread with care regarding the variations, keeping in mind the anatomy to provide a good block for a better success and preventing the lesser the complications. I thank you for your kind attention, and these are my references.
Thank you, Dr. Jagadish. A wonderful talk given with the anatomy and its implications during anesthesia, regional anesthesia, especially the variations. And most important, what I learned from him, and also you should, all the members who logged in also know the variations of the vascular structure. Sometimes in a, if you using anybody using ultrasound, you always see the put a Doppler. You see any arterial flow, any vascular malform, the anatomical variation, and avoid your puncturing the arterial or a venous. Second thing is most important is the variations of the structures itself, a cord itself. The plexus cells, there are a lot of variations. He described very well, and everybody should know. Sometimes when you do a landmark technique or a just a PNS, sometimes we may get some stitch. Sometimes we may not get a complete, all the nerves may not block just because of the variations of this plexus. The different, he already told that if you give a interscalene block, the C5, C6 is coming in the groove, it comes through the anterior scalenus muscle. Sometimes we miss it. We always give a landmark technique or a PNS technique, will go through the interscalene groove and give a drug. The drug may not reach the C5, C6. That's why we will not sparing effects will get. That's why wonderfully described by Dr. Jagadish. I appreciate him. I hope everybody is enlightened about my his talk. If any queries are there, I think that Jagadish will take the questions. Now, this topic is open or will, yeah, sir.
Yeah, I think Jairam sir wants to add in. Please, sir.
Yeah, please, sir.
Jagadish, it was an excellent talk. Once again, as Dr. Kuchela mentioned, but among the variations, the 2 approaches, one is a transhumeral approach in fractures, and there is another plumb bob methods. I don't know myself what it is, whether I have come across or not. Would you like to highlight on these 2 points?
One thing, sir, with the advent of ultrasound,
Yeah.
I think of late, most of the places, except few very primary healthcare centers, we might not find. But I'm sure even in the tier 2 cities, the ultrasound in the hospital or anywhere is quite a common thing. Most importantly, we would like to emphasize the presence of scanning techniques. The most importantly, as sir said, we need to check the Doppler in every step when we are planning to give a nerve block. So this particular thing with respect to be it advancing proximally or distally to find out what are the variations have been seen is very important according to me.
Thank you.
Jairam sir, can I add to that?
Yes, please.
Yeah. The other thing is, if we can do a scout scan before pre-procedure, in the sense, before we get the needle in, it's better we try to scan the nerves and see at which point of my ultrasound is the best possible nerves do I see, because the nerve should cut 100%. I mean, perpendicular to the beam should cut perpendicular to the nerves. Like, for example, I'll give you a small example. When we are doing a popliteal sciatic nerve block, where we feel that we are perpendicular to the popliteal fossa, but unfortunately, many a times we need to tilt the probe slightly kefled, so that at that point the beam cuts 90% and the structures are very clearly seen. Now there the structures are just one below the other, and if you don't see properly, as you said, as sir was mentioning, that in the inadvertent drug getting into the vascular structure is very high. So that is the time when we get into. So it's recommended that we do a scout scan, not once, twice. Make sure which is the best possible position the nerves are seen, and then we go ahead with the block.
Thank you.
As sir said, sir, the most important of pre and post scan after the block and before the block becomes very important as a beginner and even for experienced people like us. So as the most important, like what sir was trying to tell regarding the beam, if at all we are looking into any structure which has vascular structures around, if you can see the blood vessel in a clear circular shape, it means to say your beam is going very perpendicular to the structure which is flowing around. So this becomes very easy for someone to identify whether my probe is in the right direction or not.
I am not seeing any questions or comments in the chat. Balbas sir or Gurudas sir, you want to add anything to the discussion before we move to the second topic?
Yeah, but excellent talk, Jagdish, and the slides were fantastic and beautiful figures, and anybody could understand whatever you are talking about. And what is more important here is the zona anatomy. One has to be very good because this is PG's postgraduates. Today, actually, I was discussing about brachial plexus block only for my exam going students, upper limb blocks. So I was telling about there are about 77 variations in brachial plexus anatomy. And it's so difficult to identify these kind of so many variations in the brachial plexus, and many times because of these variations there can be patchy block, and you should know how to manage these patchy blocks, because at least distally where is the nerve which is coming, identify the nerve using your probe, and then you can block the individual nerves. That's what you are telling about the forearm blocks and then the wrist blocks. Definitely these will help. But whatever it may be, a student has to be very good in zona anatomy. Yes. And another thing is your equipment also should be very good. So unless your equipment is very good, probably we may not be able to identify every variation of the brachial plexus that is there. So extremely important. Before, we were not bothered about this zona anatomy when we were students and when we were teaching before. We're only talking about the anatomy of the brachial plexus and how to give these landmark techniques were very, very popular. Of course, nowadays it's entirely different. And what I have seen is, the youngsters are picking up very well these the zona anatomy and the blocks. Success rate has gone very high. Really, hardly we see that, especially the brachial plexus failing or any sparing of the nerves. Very, very few incidences where we can have some sparing of the nerves. But ultrasound really, we have to salute to the ultrasound technique, and which has revolutionized the regional anesthesia technique. Okay, thank you, Jagdish. Thank you very much. Nice talk.
Sir, just to add to your comments, if at all we are using an ultrasound and we don't see the needle or we don't put the zona anatomy and we are performing, it is worse than performing a landmark.
Correct.
We are surely going to land in trouble if we are not going to see the needle or we are not aware about the zona anatomy. It's better to perform a good landmark guided in an expert hand, provides much better results and lesser complications if a novice takes an ultrasound and doesn't know what he's doing.
Yeah. Especially the tip of the needle. Where is the tip of the needle? Because initially in early 2000s when ultrasound was introduced, they were telling that the complication rate was as much as the landmark technique, because people were not able to visualize their tip of the needle, and they could go into the vessel, they could even puncture the pleura. So the complications were as many as in the landmark technique. Of course, now the complications rate has tremendously come down. Yeah.
Yes.
But only thing is, what I suggest to the youngsters is, they'll all learn only about the ultrasound. In majority of the hospitals now, medical colleges, ultrasound is there. But once they go for practice outside, so it is not possible to have an ultrasound everywhere. So what I suggest is they should know the regular anatomy, and also they should know how to do a landmark technique or paresthesia technique, and also using a peripheral stimulator technique also. It is always better. We should teach them also this, not only the ultrasound guided, because many of the places, ultrasound is still not available in India. So that is also there. Like I still remember Mahavir Jain Hospital had come only to teach this.
Yes, sir.
In one of the workshops of IRO
Yeah.
workshops. So I was
Yeah.
called in only to teach the landmark techniques.
It was a wonderful opportunity.
Nobody can beat you, sir.
I was with you,
Landmarks.
sir.
And
A wonderful opportunity.
and other things, sir, as you were mentioning, because we see, because this is a postgraduate session, what I feel is nowadays when we postgraduates are using ultrasound for block, they insert the needle, and the footprint and the needle should be in one line. Now they feel it's okay if you don't see it, but what I teach is it is not okay, first of all, because the whole purpose of the ultrasound, as Jagdish was mentioning, gets defeated when we don't see the tip of the needle. We may be seeing the shaft, maybe we may get confused to the thinking that it's the tip of the needle. That is one. Second, in the intercostal interscalene block, when we are giving a block, we should make sure not necessarily the drug has to get into the vertebral artery to create problems. Even there are incidences where even the local anesthetic touching the vertebral artery can throw a seizures. That is other thing. And third, for any postgraduate, it is much easier if they follow a certain kind of side headings. Like for example, when you're giving because majority of the times, Gurudat sir, I think you'll agree, it's always a landmark guided that is being asked in the exam. It's not sono anatomy. So in that case, it is the patient's position, anesthesiologist position, point of entry, direction of the needle, needle endpoint, drugs, and if there are any complications. If we kind of follow this kind of a grid as a side heading, it will be much easier for them to answer in the exam. Thank you, sir.
Yeah. Dr. Jagdish, there are a couple of few questions in the chat box. The first one is, what about lignocaine with adrenaline for blocks? Can we use? From Dr. Srinivas.
If at all, there have been multiple areas and discussions regarding this. Point one, if at all we are using in areas like axillary nerve, axillary block. One thing is, since there have been few protagonists like that they use lignocaine with adrenaline just to elicit if there is an intravascular injection. Point one. Secondly, the presence of lignocaine as a short-acting agent doesn't give us a opportunity to provide post-operative analgesia. It is not a contraindication, but if we think in a broader sense of providing the post-op analgesia, it doesn't make. We lose the chance of it.
No, one thing I just want to add here, Dr. Jagdish. So you see, when we are using ultrasound guided plexus blocks, so the total volume that we use can be drastically decreased. We need not to give 35 ml, 40 ml like what we were giving. So when you reduce the volume, so there is no point in adding adrenaline, because majority of the times when we add adrenaline, mainly to decrease the toxicity so that you can increase the volume. Like 7 milligram per kg body weight is with adrenaline. So no need.
Yes,
and you can straight away use bupivacaine alone or ropivacaine or whatever the local anesthetic, because the total volume you are going to give is much less, and you are within your safe limits of these total dose. So absolutely. I don't think we should be using adrenaline and its problems associated with.
And sir, and particularly a lignocaine with adrenaline in, for example, sciatic nerve block. Now, if you take sciatic nerve block, the sciatic nerve has intraneural arterioles. And when you're using adrenaline, sometimes they can get into a spasm. And it was my first block way back in 2007, which I will never forget, where I had used lignocaine with adrenaline. And it was a night where it took almost close to 36 hours for him to get back the sensation. And that creates a lot of stress for the patient, for the anesthesiologist, a lot of things goes in. So as sir says, there is no added advantage, because with ropivacaine around, with bupivacaine around itself, we get about 8 to 12 hours or 14 hours of post-op analgesia. So that could be sufficient, I guess.
Yeah, we'll take quickly some more questions, and then before we move to the next topic, Dr. Anil Kumar wants to know why routinely intercostobrachial block needs to be done. Jagdish?
It is not routinely required, sir. It depends on this is why I mentioned that the sensory innervation of the upper arm needs to be known. Say, for example, if we are doing an AV graft, where the incision is going to be in the upper part, uppermost medial part of the arm, then yes, intercostobrachial nerve is very much required. Whereas if we are, say, operating on a Colles fracture, there is no point in giving an intercostobrachial nerve block. So it depends on the sensory innervation and the surgeon's incision, depending on which we can always tailor make our block.
And
usually, Dr. Jagdish, so intercostobrachial we used to give, because the tourniquet. So
yes,
the tourniquet can be there, and then it can produce some amount of pain for
Yes,
the
sir.
patient. That's why routinely intercostobrachial nerve we used to block that separately.
Yes, sir.
No, is it required now for if the surgeon is applying the tourniquet?
No, musculocutaneous nerve, most of the time we'll use a musculocutaneous nerve for the tourniquet pain, not the intercostal.
Exactly.
correct. And what sir is saying is, when we give about 5 mils even in musculocutaneous nerve, sir, 70 to 80% of the tourniquet pain is taken care by musculocutaneous. Or the gold standard is just to infiltrate around the arm. That is has been the gold standard for intercostal brachial. So which I don't think is anymore recommended.
You recommend.
Now, one more thing is, suppose if it is a post-fixed brachial plexus, as you said, that 7.5%, there can be a post-fixed, where even the intercostal brachial, because it is from T2, that also gets blocked. Then I think one can check whether the intercostal brachial plexus, the nerve also has been blocked. Otherwise, as Dr. Azam was telling, that you just give a subcutaneous block of 2 or 3 cc just in the just anterior to or lower down in the axilla, you can just give. That's what.
If at all we have an ultra, we can just start infiltrating the drug just above the axillary sheath, which usually is a gold standard.
Yeah,
we can block most times the intercostobrachial nerve. And if at all planning to give a supra-axillary nerve block, again, there have been many studies which says that the intercostobrachial nerve is covered in this particular block.
Okay, there is one more question. How much of soda bicarbonate has to be added to the local solution? Are there any particular recommendations for it from Dr. Anusha Hiremat?
Sir, we have never used soda bicarb as an additive, sir. I don't see
otherwise, in olden days we used to add. Sometimes for students it is very important because in the exam they may be asked. So for lidocaine, for every 10 ml of lidocaine, 1 ml of 7.5%.
To improve the onset of the action, most of the time, the olden time, you are teaching like that. Your onset of action will increase once you add a soda bicarb. Now we have a lot of additions that come out. Now we are adding for every fentanyl, clonidine, dexamethasone. These are also making not only increase the duration of action, onset of action also increase by these additives. Now that's why soda bicarbonate now we are not at all using.
No, the other thing is, because ultrasound guided block, so the success rate is very high. As you just take out the needle, already the patient is having the block. So there is no point in using the sodium bicarbonate. But for exam purpose, because this is a PG lecture, so they will be asked. So 1 ml of 7.5% sodium bicarbonate for every 10 ml of lidocaine. 0.1 ml of sodium bicarbonate for every 10 ml of bupivacaine. So let them just remember this for the purpose of answering in the exam. That's all.
Yes.
Sir, Gurdas sir, olden days we are used to use some enzymes also, especially to increase that onset of action. Even though ultrasound is not there, we are used to use that.
There are a few more questions. I think we'll quickly take them. Dr. Azam will be waiting to start his presentation.
No problem. Those are important.
Again, Dr. Anil Kumar is very active. What is your opinion on upper trunk block? We use it routinely. Gurudas sir, your department, please.
Yeah, correct. They do a lot of upper trunk blocks. Dr. Anil and Dr. Anu.
For shoulder surgery, sir.
Yeah,
we do.
Again, it is again targeted nerve blocks. So whenever we are planning to have analgesia for shoulder surgeries, upper trunk blocks.
For clavicular surgeries, they are using quite a bit because just 6 to 8 ml of the drug they are going to inject, and along with the superficial cervical plexus block. So clavicular surgeries are done in our hospital.
Okay.
You
There
call
is one more
scut block.
question.
Scut
Yeah.
block.
Scut block, yes.
Okay. Dr. Parimala is asking, sir, can we go ahead with combination of brachial plexus blocks like supraclavicular with interscalene?
Yes.
No. Why?
Why?
Not at all
They-
necessary.
first,
Why? What is
there
the
is
why
nothing wrong,
necessity?
but is
The
there a necessity?
same nerves you are blocking, except the high level. Why
Yes,
you
sir.
need it? Indication.
Jagdish, you want to take the question or should I answer?
Yeah, please answer.
You
I
can.
think it not necessary. My
No,
opinion,
sir.
but yeah.
Since we are, because of the ultrasound guided, yes, we do use routinely when the volume decreases. When the volume decreases, when we start using, like we have personally used about 4 ml for axillary nerve block. We have used about 7 mils for supraclavicular nerve block, and we have used as less as 4 to 5 ml for interscalene. So in those cases, yes, we do use a combination for faster action. But otherwise, yes, if you can use 25 mils to 30 mils, even 20 mils is quite good enough, or even 15 mils is good enough, then not required. If your volume is reducing, yes, but otherwise not required.
So Dr. Anil is again asking some exam questions for postgraduates benefit. Separate use of local anesthetic agents or mixture. Does it make any difference in practice?
No,
I
sir.
don't think so.
We have always given only used ropivacaine.
A single
and it has given very good results. Prolonged action, faster onset. There is no need.
In our hospital, we are regularly mixing lidocaine and bupivacaine. So that's
We
why
used to
Dr.
do
Anil is
that.
asking.
We used to do that before. I think from
No, what
past.
Gurudat sir, now of adding additives, it is also it take care of all things.
Yeah.
Adding onset of action and duration of action. If you give fentanyl or dexamethasone or something like that, it will take care of onset of action and the duration of action.
What's your thoughts on mixture, sir? Gurudat sir?
Yeah, that's what theoretical thing about mixture is, lidocaine, because it is faster acting. So probably the soaking time for the brachial plexus block will be short. So later on, the long duration of the other local anesthetics like bupivacaine, ropivacaine, they'll take over, and probably that will help. That's the reason why the mixing of these were being done. And till now, we have not had any problem. We don't know actually what is the physical reaction between lidocaine and bupivacaine or long-acting drugs. What is the chemical reaction between them when we mix them? So ideally speaking, we are not supposed to mix two drugs.
Yes,
Ideally
sir.
speaking, but practically what we have found is since ages we are mixing and then giving, we have not had any problem. So we can continue, but you can use only a single drug because the volume requirement is much less. Success rate is high and onset of action is very fast with ultrasound. So all this mixing the drugs may not be required now.
Jairam sir, you wanted to add something?
Yes, in fact, when we were studying, me and Dr. Gurudat.
Yeah, we were classmates, myself and Dr. Jairam, right?
and we never had all these drugs or equipments except the needle and lignocaine and bupivacaine occasionally. But successful rate was equally good, I would say. We were taking good care of the patients. What do you say, Dr. Gurudat?
Yeah.
Dr. Azam, you want to take this from Dr. Rashmi? Where would you prefer your monitor to be with respect to patient and anesthesiologist? Maybe multi-parameter.
You mean the para?
I think patient multi-parameter monitor or ultrasound monitor. I'm not sure.
When I'm giving a block, yeah, majority of the times it is almost at the head end, sir. No point in shifting and things like that. So we get the patient to the operating theater, make him lie down as usual, the machine at the back, and monitor. But the thing is, you need to keep your ears open. We need to keep hearing the beep. And on that basis, we go ahead. Even a slight changes, we make sure we always speak to the patients, make sure they're comfortable. We always have a conversation when we are giving them blocks.
Always the monitor is on. Especially the SpO2 and the ECG should be attached.
Yes, sir.
If the question is the PG asking about the monitor of the vitals, monitor should be on, wherever it's kept. And I think his question is about the monitor of the ultrasound. Always ultrasound should be the ergonomics, the placing of the patient ergonomics is the most important for the who is performing it. The monitor should be opposite to your head. That means when you are doing a intrascleral is opposite. If you're doing a suprascapular, it is same side. That is depending upon the how you are using, what are the technique you are using. Auxiliary, where you are using the same side, you can use it. Like that, that is ergonomics of the during a ultrasound, where the monitor should be there, where the performer should be present, and how the patient should be head and how it should be elevated, how propped up, like everything. These ergonomics already it is described. That should be taken care of. If they are thinking about the technique, if the monitor is there, all the monitors should be attached and should be everything should be ready. And also IV line should be there. That is a must.
Yes, the anesthesiologist, the point of block where we are intending to block, and the ultrasound machine should be in one line, and it should be in front of, as sir was mentioning, back in front of us, so that we don't, we don't get into uncomfortable position when we are giving a block. Yes.
Dr. Jagdish, one more question from Dr. Jayaraja. How about placing catheter in upper limb blocks for post-op analgesia?
We regularly do, sir. I think Dr. Azam's next talk will even cover that.
Okay.
I think he'll more details into what he's looking forward for.
Yeah, and
we do it quite regularly.
Okay. And there are some comments like Dr. Sadish has informed mixing of local anesthetic has theoretical disadvantages, and difference in pH does not matter when lidocaine and bupivacaine are mixed. I don't know whether it is a comment or a question. Okay, there is one question from Dr. Soundarya. What is the minimum volume of local anesthetic needed for blockade under ultrasound guidance at each level without additives?
Yes. For example, let's start from interscalene. It based on the experience that you have, how often you're doing, how used to you are to the ultrasound. And in that cases, we have now been practicing for quite some time. We have come down to a level of about 5 to 6 ml for your interscalene. And I have used as least as 6 ml for supraclavicular. And our postgraduate is also on the participant list, Dr. Harish. He's one of his topic is low volume supraclavicular nerve block, which we are doing, which is about as least as 7 to 8 ml. And axillary I have done least is 4 ml. But the problem with axillary is if you're giving 4 ml of local anesthetic, you need to give minimum half an hour to 45 minutes because they are myelinated sheath. It takes longer time for the action. So we had a patient who was undergoing total abdominal hysterectomy. At the same time, she had, had to undergo amputation of her 4 fingers. So in that case, I had given an axillary nerve block with 4 ml because total abdominal hysterectomy took about an hour and a half. So in meantime, it had worked well, and we went ahead with the amputation. So that is what it is. But supraclavicular, interscalene are instantaneous. You're giving a block, and patient can feel the numbness in the hand.
Okay, we'll take one last question from Dr. Naveen. Role of peripheral nerve stimulator with ultrasound guidance for noise.
Yeah, that is good. That is always be welcome. If you're doing that one, it's a 100% the safety is improved and the quality of the block will be more. I hope. I think the Jagdish can comment.
Sir. The use of dual modes are very essential in few blocks like lumbar plexus or sacral plexus. We particularly cannot perform these two blocks without the dual mode of using for peripheral nerve blocks. Whereas when it comes to supraclavicular or very brachial plexus block, for a novice there is nothing wrong, and in fact it gives a good indicator of which block is being performed, and you can even see the motor functions of the muscles when he's doing it. But nothing wrong for a novice to use both the modes. But for respect to lumbar plexus and sacral plexus, even for an expert's hand, it definitely requires both tools to aid for a good block.
Okay, I think we had a very good interactive session this time.
Ganesh sir.
Yeah, please, sir.
Yeah, thank you very much for giving the opportunity.
Sir, we have one more session, sir. Please, I think.
Yeah, definitely. I'll be there.
Yeah. I forgot, Dr. Jagdish, your quiz questions were not put. I think can you share the slides and we can quickly finish that and then move on to Dr. Azam's lecture. I find that a lot of postgraduates are there, so it will be good for them as well. Yeah, I request the participants to answer the first question with question one and then answer A or B or so. Yeah. Please project the slide. You can read out the question, Dr. Jagdish.
So the first question is, whenever we are performing surgeries where shoulder and the proximal arm are involved, apart from interscalene block, what supplementation would you like to give?
The participants can type the question number and the answer. The fastest correct answer will get a certificate of appreciation from ISA Karnataka, as has been our tradition. I don't, Jagdish, you're not timed the answer, right? Only on click.
No, no, not.
Okay.
Yeah.
Fine. I think this is a tough one. I don't find anyone typing their answers.
You don't have to give a posterior cutaneous nerve of arm block separately. You don't have to supplement. It's a branch of the radial nerve.
Okay. The second one.
Which of the following tests are supposed to be used to assess whether the median nerve is blocked or not before you do any surgical procedure? Would you like to pinch at the palmar base of the little finger or the index finger? Would you like to resist pulling the forearm at the elbow, or would you like to push the arm by extending the forearm at the elbow against resistance? Which one do you like to do? To test whether the median nerve is blocked or not.
Please type your question. Raising the hand will be difficult. Please type your answer to this question number 2 in the chat box. Dr. Rashmi, you can type it in the chat box. Dr. Sandeep God also can type in the chat box, please. Yeah, all those who are raising your hands, can you please type in the chat box? Yeah, Dr. Soundarya has answered. Yeah, I think you can move on. Give your answer, sir, and move on to the next.
Always have to distinguish whether there is a pinch at. Is there a distinguishing thing when he pinches at the palmar surface of the index finger? That would probably tell whether the median nerve is blocked or not. The third one. What are the anatomical variations which can be seen during interscalene nerve block, which is not usually seen? Do we get to see the presence of accessory phrenic nerve? Is there variations at the divisions or nerve root levels at this level? Do we see the presence of C6 nerve root within medial scalene? Is there C5 nerve root in anterior scalene? Which one do you don't see?
Sorry, I think the chat was disabled earlier. Now it's working fine. So you can please type it. You can give the answer, sir.
I can give, sir?
Yeah. Because a lot of responses are there.
So the presence of C6 is usually not seen. These are the various commonest variations that we can see in the interscalene area. There will not be the presence of a C6 nerve root in the middle scalene. This variation is not seen.
You are done with all the. You had 4 questions.
Yes.
No?
Yeah. You told me to reduce it to 3. So
no problem. Okay, fine. I think that should be fine.
Yes.
Thank you. And
Yes.
I think we have got some responses also. I'll type it in the chat box without wasting time. We'll move on. Yeah, it's already now. Yeah, 7:40. Thank you, Dr. Jagdish. And we'll move on to the next speaker. Dr. Azam, you ready?
Yes, Sri Ganesh.
Yeah. With the permission of moderators, Kuchala Babu sir and.
Yeah.
Okay, fine. Please go ahead.
I'll share my screen. You're able to see my screen?
Yeah. You're audible and the screen is seen. Please go ahead.
Yes, sir. All right. Good evening, everyone. Respected chairpersons. And at the outset, I would like to thank the entire team of ISA, especially Dr. Balabhaskar sir, Dr. Vijayanand sir, Dr. Sri Ganesh, Dr. Gurudat sir, Dr. Shiv sir. Thank you so much for giving Jain Hospital this opportunity to share and gain knowledge. So with this, I'm presenting my case of post-COVID, where patient had a thrombotic sequelae with upper limb ischemia and perioperative anesthetic care for pain management and above elbow amputation. Now, this was 37-year-old female, known case of diabetes with history of COVID positive status, was home quarantine, now comes with acute limb ischemia, and she was also amenorrhea of 7 weeks. She was G2P1L1. Initially, she was admitted at Manipal Hospital, where the CT angio done showed thrombus in the left subclavian artery. Hence, underwent a left upper limb thrombectomy and fasciotomy of April 7th. Her COVID markers were not much changes except for the D dimers, which were about 0.6. Her ferritin and LDH was a bit marginally raised. Patient was worked up for the various etiology. Most of the investigations were normal, and she continued to be having a pain in her left upper limb. She continued to have numbness of the left hand and inability to move fingers. Hence, she was advised to undergo left above elbow amputation. Now, this is where she came into Jain Hospital for second opinion. Patient was started on patch buprenorphine and fentanyl IV infusion of 25 mics, but it was of no gain. Then we were requested, anesthesia team was involved to give a supraclavicular nerve block. We decided to give her a supraclavicular nerve block in view of, though she was a COVID positive, though she was not in any respiratory distress. Hence, we decided to give a supraclavicular. We'll come to the details later in the slide. With 0.2% ropivacaine, 20 ml, and we had a catheter in place using ultrasound guidance. Continuous infusion was started about 0.2% ropivacaine at 5 mils per hour, which was escalated to about 7 mils per hour, and patient was comfortable on day 1. The following day, again patient complained of pain. The infusion was increased to about again 5 to 7 mils per hour, which was already increased. But what we noticed was there was a leakage from the catheter insertion side, and infusion was stopped, and we did an ultrasound to show that there was already misplacement of the catheter, and the catheter was removed. On 12th April, again ultrasound of the left prostoclavicular block with 12 mils with 0.2% ropivacaine, and a catheter was placed, and a continuous infusion was activated at about 3 mils to 5 mils, and was gradually increased to 7 mils till about 15th of April. Later, infusion was tapered, and patient was comfortable. Patient underwent medical termination of pregnancy for various reasons. Catheter was removed, and patient was discharged on 21st April to get a above elbow amputation at a further date, so that it can have a proper demarcation. Right. Now, she was readmitted again on 18/5 for above elbow amputation. Now this initiated me to present this topic today for the webinar, where which block to be given. Yes, we did try supraclavicular block. So performance volume supraclavicular versus lateral sagittal clavicular brachial plexus block versus costoclavicular block. Now, the other question that came into my mind was costoclavicular block, ease of catheter fixation when compared with lateral sagittal infraclavicular brachial plexus block, which is usually done, versus supraclavicular block. Again, in that, we again thought we should be able to discuss about catheter in lateral sagittal infraclavicular brachial plexus block versus costoclavicular brachial plexus block. And we also felt what were the issues when we used supraclavicular catheters. Why did the catheter came out? And what was the maintenance volume when compared with lateral sagittal versus costoclavicular brachial plexus? Now, we all know that we have now a new block which can be used as an armatorium when we require to block such patients who are COVID, who are having a high respiratory rate, where we cannot give supraclavicular or interscalene. Do we have something? Yes, we do have something. So let us see about costoclavicular brachial plexus block, sonoanatomy, technique, and block dynamics. Now, the infraclavicular brachial plexus, as we all know, refers to the 3 cords of brachial plexus, which are placed roughly about 3 to 6 centimeters depth. They are the lateral cord, medial cord, and the posterior cord, and they lie all around the axillary artery distal to the clavicle. There are about 12 branches emitting from the cords, of which 3 are from the lateral branch, 5 are from the medial, and 5 from the posterior. But in this case, 5 plus 5 plus 3 totals about 12. That's because the median nerve gains innervation from both medial and the lateral cord. Now, if we're to ask you the most frequently used technique for intercostal brachial plexus block, the answer would have been the lateral sagittal infraclavicular brachial plexus block. We perform a sagittal scan in relation to the coracoid process, look for axillary artery, which is usually deep to the pec major and pec minor, and this is the axillary artery. Let me play the video. So what happens is, this is what we see in the ultrasound. We see the lateral cord. We see the lateral cord that is here. We see the lateral cord that is here. And the rest is all imagination. Yes, we do understand that there is some amount of imagination in ultrasound. As I said, the 3 cords, the brachial plexus, are located at about 3 to 6 centimeters depth. There are significant variation. It is not as textbook described, like you see, at 3 o'clock, 6 o'clock, and 9 o'clock positions. Unfortunately, it's not going to be like that. Right. And when we use for surgical anesthesia, unless we do not use higher volumes, particularly for the lateral sagittal infraclavicular brachial plexus block, we will be heavily disappointed. There are limitations in this approach in performing brachial plexus. Firstly, the cords are located at a greater depth. Cords are separated from one another. There is significant variation in the position of the cords in relation to the axillary artery. It is never 3 o'clock, 6 o'clock, and 9 o'clock, as I mentioned. Very rarely we see all the 3 cords in a single ultrasound window. Hence, when we use this, we need to use large volumes to overcome this limitation. We also give multiple injections, maybe 2, sometimes 3. Dr. Tran, who has already done so much of research on this and published many papers. Finally, when we put a catheter, it is usually recommended in a lateral sagittal infraclavicular block to place a catheter posteriorly to the axillary artery, because the posterior cords lives there. Right. When we are using for anesthesia, when you are using a block for anesthesia, we usually the recommended volume is about 30 to 35 mils. But unfortunately, when we're using a catheter for post-op analgesia, we're not using 35 mils. We're using only 5 to 6 mils. So what happens? Only the posterior cord gets soaked, and this will lead to secondary failure, and the patient may not get a good post-op analgesia. So it is quite, what I should say, surprising in the era where we are using lesser volumes, why to use larger volumes? And this stimulated Dr. Manoj Karmakar to do a research after he read an article from the American Neuroradiology in 2003 by a Demodian group. They showed that when a scan is performed inferior to the clavicle, with the transducer at the midpoint of the clavicle and slightly facing cephaloid, the clavicle, what we are looking at, a potential space that is between the chest and the clavicle, is called the costoclavicular space. So this is what was his publication and was his innovation. And the number, when he saw this on the ultrasound, the number 5, 6, 7, those are the cords that are lying in one ultrasound window. And this is the axillary artery, the number 3, and this is the axillary vein. So Manoj Karmakar thought, when all the 3 cords are seen together, why do a technique? And he started, why do a technique when we have to struggle so much by giving, a piercing a couple of times, giving large volume of drug? So he started his research on the cadaver studies. Now, this is from the cadaveric study. Here, if you see, this is the clavicle. This is the clavicle. This is the muscle below that is the subclavius. This is the collapsed axillary vein. This is the axillary artery. There is a small opening that is the thoracoacromial artery. And then the lateral cord. What we see here is the lateral cord. Then we see the posterior cord that is shown here. Right. Now, once we cut the clavicle, where these are the cut edges of the, yes, these are the cut edges of the clavicle here. When we take it out, we see a muscle that is subclavius, which is very prominent. Again, we see the lateral cord, the axillary artery, the lateral cord, and the posterior cord. Okay. Now, in this cadaveric dissection, when we retract the lateral cord medial, that means here, when we retract the lateral cord medially, we can see the medial cord here, which is just behind the lateral cord and at a slighter depth. The feature is that, like I was mentioning to you about the common peroneal nerve and the tibial nerve, they are the buddy nerves. So he named these as the buddy nerves. The posterior cord and the medial cords are like buddies, like how the common peroneal and the posterior tibial tibial nerve goes in hand. They are the buddy nerves, like same wise or the likewise. The posterior cord and the medial cord are buddies. So what is its anesthetic implication? So if we are performing an injection, do not try and separate the posterior and medial cord, because if we try to do that, we may get into intraneural, which is not good. Like here in this cadaveric cross section of cadaver, we see this as a clavicle. We see a subclavius muscle. It's very important to see the second rib here. These are the cords that are arranged. This is the axillary artery in the red, and the blue is the axillary vein. So this is the lateral, and this is the medial. All right. Now the histological section. This is it gives a better. It is better defined here. What happens is, if you see the lateral cord here, and we see a posterior cord here and the medial cord here. So if you have a close look here, the both posterior and the medial cord are covered in this sheath. This is this one is the sheath. Yes, this is the sheath. So they are covered in one sheath, and that is why we always say look at the connective tissue layers that covers both the posterior and the medial cord, which gives you a buddy-like appearance. Now, how to perform a scan? This is something that every individual who performs brachial plexus block should know, the relationship of the cords from the lateral sagittal infraclavicular brachial plexus to the costoclavicular. No point in getting the footprint or the probe directly into the below the clavicle and start scanning. You always start from your lateral sagittal and come to the costoclavicular. I will show you in my further slides about the placement of the catheter. You can see how the cord rotates into the position, and the cephalic vein and the anterior, which is anterior to the cords. So a linear probe, I will play the ultrasound, then we will get to know properly. See, I'm moving the cord. So the initial goal is to identify the axillary artery, the first part of axillary artery, that is above the upper part of the pec minor, which is the first part of axillary artery. The ultrasound beam is directed, as I said, slightly cephaloid to aim at the serratus anterior and the second rib. Right, this is the axillary artery. There is the serratus muscle, and here is the second rib. Right. Now, we were discussing about ergonomics. This is very important. The ergonomics, so I was mentioning, they should be all in the same line. Either you can keep it here. This is taken from Dr. Manoj Karmakar's book, or you can place the ultrasound machine right in front of you. So whichever you're comfortable, but make sure you don't strain yourself when doing. Now here, the arm is abducted. The arm should be abducted, but one of the limitations in which we cannot abduct the arm, there is a limited space in lateral aspect where inserting the needle becomes very challenging. So hence, if the patient cannot move the arm or abduct the arm, we may have to choose some other technique. These are the dermatomes, myotomes, and osteotomes. And coming to the technique as such, because the injection is at the costoclavicular space, it's called as costoclavicular brachial plexus block. One may see the cords. You can systematically evaluate and see that they are clustered together. So linear probe, as I told you, and the transverse scan at the midpoint of the clavicle. The focus is to define the sonoanatomy and to develop a technique that you can perform a costoclavicular brachial plexus block. Let's interpret this image. Now here on the left side, we can see there are three round yellow structures. This is the lateral cord, this is the medial, and this is the posterior cord. This is the axillary artery, this is the axillary vein, and this is the subclavius muscle, the needle coming in, and this is the secondary. So if you have to label this, again, the lateral cord, the medial cord, the posterior cord, the axillary artery, the axillary vein, and this is the costoclavicular space, right? If you place an ultrasound at the midpoint of the clavicle and slightly facing cephaloid, this is what we see. We have the axillary vein, we have the axillary artery, we have the subclavius muscle here, right? We have pec minor, then as I said, artery, then we have cephalic vein, which is very, very important to identify. And there is an anesthetic implication, which I'll be discussing in my further slides, and so on. Right, to interpret this image, we place a cord with the hand abducted. We place the cord just below the clavicle and slightly cephaloid. This is what we are supposed to see. We see a subclavius muscle, right? We see the posterior cord. We see the medial cord here, medial cord, and then the lateral. This is the axillary artery, this is the axillary vein, and the secondary. So this is the lateral, this is cephaloid, this is cephaloid. This is cephaloid, this is caudal, and this is medial. This is medial. Now, there are 5 sequential steps that we need to do in a systematic way for scanning of this costoclavicular brachial plexus block. The scanning is performed in a very systematic way of 5 sequential steps. As I tell my postgraduates, you have to have a repeatable routine that will give you a consistent images. Whether you scan on a Monday or on a Saturday, an image should be depicted in your mind. If you close your eyes, you should be able to see the ultrasound image that you're going to. That is the amount of training you need to train yourself to get that following image in your mind when you place an ultrasound. A routine must be followed. First step is to scan over the clavicle, and we can still, we just dip the probe below the clavicle at the midpoint. The aim is to identify the structures which are relevant and should not be visualized when you're doing the costoclavicular brachial plexus block. Now, this is the first step where we keep the probe on the clavicle. Let me play the video. We see a acoustic shadow. This is the acoustic shadow here, right? That's all. This is the first step. The second step here is when we start scanning, let me play the video. Here is the axillary artery, the axillary vein, this is the subclavius muscle. We can see the nerves arranged here. And this is not to forget the pleura, right? So I hope you're able to see. I'll again play the video. Yeah, this is the pleura, this is the axillary artery, axillary vein there, and these are the cords that are sitting. And this is the subclavius muscle, right? And this is the secondary. Okay. Now the third step would be to identify, like the cephalic vein arches around the deltopectoral fascia at the deltopectoral groove to join the axillary vein from the lateral to the medial direction. If you're doing a costoclavicular brachial plexus block and you see a cephalic vein, it implies that you're too low. So you should move the transducer more cephalite. Ladies and gentlemen, if you see the cephalic vein and you insert the needle, you will be puncturing the vein. So you here in this same video, you can also see the pleura and you can also notice the sliding sign. Let me play this video. This is the axillary vein. This is the axillary. No, this video, there's some problem. Okay, let me see the next one. Next video. Next one. Yeah, this one. Yeah. Now here, let me play the video. Yeah, this is the axillary vein, and the cephalic vein is draining into the axillary vein. This is the axillary artery, and the cords are arranged here. This is the second rib, and subclavius muscle is, because we are seeing the cephalic vein, we are not able to appreciate the subclavius muscle. Right. Now, if I, as Sir was mentioning, the importance of the Doppler, it is very important to place a Doppler. You can see the cephalic vein draining into the axillary vein, and the pulsatile is artery. Not necessarily red is an artery and blue is a vein. It could be the other way around. It just depends upon the blood flow to the towards or away from your transducer. Right. Now, again, I'll play this. This is a zoomed image. What I've done is I've little zoomed in. And if I play this, axillary vein is there here. That is the pulsatile axillary artery. Yes, axillary vein, axillary artery, and the cords. There is a subclavius muscle and pectoralis muscle. So it is pulsatile, and we should make sure we don't see particularly the cephalic vein and the thoracoacromial artery. So this is a zoomed image, and next to the artery is the LMP. LMP. So lateral, medial, and posterior cords. All right. Now, as I'll just show you one more video. The fourth step would be here, the thoracoacromial artery. The thoracoacromial artery is easily seen, which is a V-shaped here, V-shaped. It is the first branch of axillary artery. It is becoming more, it becomes more important when, with many fascial blocks. Fine. Now, as Sri Ganesh was mentioning, what are the branches of thoracoacromial artery? If you can leave a message on the chat box, the options are clavicular branch, acromial branch, deltoid branch, pectoral branch, all the above. Will you please choose your right answer? I will
Yeah,
not
the participants can type their answers to this particular question in the chat box. I think it is enabled now. This is the quiz question for the second topic. Shilpa, chat is activated, right? Okay, yeah, there is the answer coming in.
Okay. So shall I go ahead, Sri Ganesh?
Yeah, please go to the next one.
Right. So let's spend some time on this, the thoracoacromial artery. As I said, the thoracoacromial artery is the first branch of axillary artery. Remember that thoracoacromial artery divides into many branches, right? Into many branches, and there are 4 consistent branches. So the simple mnemonic is cadavers are dead people. Cadavers are dead people. C for cadaver, C stands for clavicular branch, R, A is R, that is acromial branch, D is dead, that is deltoid branch, and P, people, pectoral branch. So cadavers are dead people. Clavicular branch, acromial branch, deltoid branch, and P is pectoral branch. So just to make things easy, this is what. These branches are consistently visualized. And ladies and gentlemen, if you see the thoracoacromial artery, it implies that the probe is too distal. You may have to move the probe more carefully. Right. Just to show once again here, this is the small pulsatile. Yes, that is the you see the small V shape. Yeah. Now you can see this V shape. That is the thoracoacromial artery. We have a pulsatile axillary artery. Then we have vein, and this small pulsatile is the thoracoacromial artery. And the 5th step is the probe over the infraclavicular fossa, where the cords are seen here. You can see the artery, you can see the vein there, you can see the subclavius muscle. So this is what I will show it to you in my subsequent slides when we are giving a block. And as I was mentioning to you, the importance of doing a scout scan. Now, when I do a scout scan, I see the cephalic vein. When I'll play this video. Yeah, I'm seeing a cephalic vein. And this is the axillary artery. See the subclavius muscle? So beautifully seen. And you have the cords sitting next to the, or lateral to the axillary artery. So now at this point, this is the point where I don't see the cephalic vein, I don't see the thoracoacromial artery, I see the cords at its best. So I stabilize my hand here and I go ahead and give a block. So my next quiz question would come here. Where would be the tip of the needle, or you can consider the tip of the catheter in costoclavicular brachial plexus block? Where should be the tip of the catheter or the needle giving a brachial plexus block? The options are posterior to the medial cord, in the center of the three cords, posterior to the lateral cord. Sri Ganesh?
Yeah, please. Audience can participate and answer, type their answer. Yeah, already the correct answer has been done, I think. Yeah.
So shall I go ahead?
Yeah, please.
Right. Now we need to define a technique that you can insert a needle from the lateral to the medial direction, passes through the subclavius muscle, and the aim is to find a cleavage between the lateral and the posterior cords. A single injection at the center of the nerve cluster should be enough. It is a fascial injection at the center of the nerve cluster. This is just to show a video of the injection technique. Let me play this. So if you see, the needle is coming here. The needle is coming here, and I'm going to pierce the fascia. I stop there and I inject the drug here, and you can see that is where the drug is getting injected, and the lateral cord is being pushed, and you can see the medial and the posterior cords here as well. So this is the axillary. This is the axillary artery. This is the axillary vein. Let me play once more. This is the needle that is coming in. Yes, now I pierce it. I'm just lateral to the lateral cord and I inject the drug. You should appreciate, or one should appreciate, the drug being deposited. That is the time we feel that yes, we are at the tip of the needle. Okay. Now, what did Professor Vincent Chan did was, he also mentions, if you're not able to see, just hydrodissect. And sometimes it will it gives you the exact location where the center is, and probably the visibility gets much better. So if it is an anesthetic technique, we can use 0.75% ropivacaine. We can use about 20 cc, but under continuous vigilance. And here after the injection, just at the lateral to the lateral cords, and make sure that we do not separate the posterior and the medial cord. This is another video. The next one. I'll just play this. Yeah. So again, the needle is coming in. I'm very lateral to the axillary artery. If you see, the drug is being deposited here, and this is the lateral cord. This is the lateral cord here. Yes. Let me play it once more again. Yes. Just keep visualizing. As the drug gets in, you can see the lateral cord much more clearer. All right. So now let me play this another. Here, I think we were passing a catheter there. That's a catheter that is coming in, and then left it at the tip of the tip of the lateral, and in between the lateral and posterior and the medial cord. Right. It was found that median nerve was much slower in onset. What are the reasons? Let us see this. Now, it was as I said, it was found that the median nerve was much slower in onset because the posterior cord here and the medial cord are enclosed in this sheath. If you see carefully, and this is the sheath that has there been enclosed, right? And the lateral cord is enclosed in a different. Lateral cord is also enclosed in a different sheath. So this probably explains why the median nerve onset is slower, because of the innervation from the lateral and the medial cords. Okay. Now, I was telling you the body appearance. Here, one can appreciate the sheath covering the posterior and the medial cord. I will just play it. I'll just play it. This is the one here. The sheath. Sorry, here the sheath is getting covered. This is the lateral here, and this is the posterior and the medial. You can appreciate the sheath there. Once you inject the drug there, it gets much more clear. Now, coming to the catheter technique, With my limited experience on catheters at the costoclavicular space, finally, I would like to finish by making a comment on catheter technique because the cords are clustered together. That is one. It is convincible that if I put a catheter in the center of the nerve, I infuse a small volume, I'll be able to produce consistent blockade of all the three cords. The catheters rarely fall out or get blocked, which I have actually noticed that. Now, what do we know today about this particular technique? In conclusion, I can say we know the anatomy of brachial plexus at the costoclavicular space with extreme clarity. We also have described a technique of costoclavicular brachial plexus block. We have defined the sonoanatomy and how consistent to achieve a good images of the brachial plexus. It produces very fast onset of sensory and motor blockade. Um, the readiness for surgery is very rapid. It improves the outcome of the lateral much compared to the lateral sagittal infraclavicular brachial plexus block. However, remember that this technique is very close to Pura. It requires some dexterity and understanding the anatomy. Otherwise, it's possible that we may puncture the Pura if you're not getting the probe and the needle in line. Right? Diaphragmatic paralysis is said to be about 5%. The study is going on. It will be published very soon by Shiva Shanmugam and team. The ongoing studies of dose required to produce surgical anesthesia is yet to be answered. So with this, ladies and gentlemen, I hope I have illustrated to you how the ultrasonography has helped us to refine in what we are doing today, and you will find in years to come as our understanding of the anatomy and sonatomy increases, the way we are performing regional anesthesia will be very different. So with this, I leave you thought to think about. This is my own picture here, the tiger picture from Ranthambore. At one point of time, I was novice to this, but now on a routine, repeatable, sessions of photography, I would be able to achieve the same thing holds good for our day-to-day practice. Thank you so much for your kind attention, and open the session for questions and answers. Thank you so much.
Thank you, Dr. Azim. A wonderful talk is given by how to do a ultrasound guided block.
Thank you.
And also, you shown a very good pictures about the videos. But only thing is, for the postgraduate purpose, you can maybe show the ergonomic, how the probe is surface markings. You can instead of only you're giving the video of the needle technique, and also how the probe is there, probe placement.
Yes, sir. I think in one of the
only ergonomics is shown. So you only shown ergonomics, but not the probe direction at the needle point of entry and the changing of the needle.
Yeah, sir. Actually,
also,
yes, I had
especially for the postgraduate purpose. Otherwise, a wonderful talk, very, very appreciated, but a way of how to identify it, what are the difficulties, what are the complications, how to come over this especially lateral cord. So
correct,
why
sir. Actually,
yeah.
I had taken video of I had taken a video of catheter insertion. I had taken a video of probe placement.
Time is
no, sir. The patient never consented for that.
Oh, okay.
So that was one of the reasons why I could not. Then I requested her if I can put it up on the ultrasound images. It was okay from their point of view, her point of view.
Yeah, very, very good, very lucid talk, and it is for the postgraduates might be benefited by your talk. If now any questions and answers,
we'll take comments from Jairam sir also, and then take some questions in the chat. Jairam sir, unmute yourself, sir. Jairam sir, you are muted. Please unmute yourself. Jairam sir, you are not audible. Can you unmute?
Sir is again.
I think he has not heard us.
Jairam sir, please. We are not able to hear you.
Unmute, sir.
Call him over phone,
sir. Ganesh, you are a host. You can unmute.
No,
sir. You cannot unmute.
He has muted, so let me try.
There
You
I
can
have sent
check.
a request to Jaram sir also.
Okay. Meanwhile, I'll just take the question from the chat. Dr. Anil has commented that hydrolocation, hydrodissection, and visualization of needle tip all the time are the key for success. I think all of us agree there.
Agree.
And Sudesh,
Sri Ganesh,
yeah,
just to
please.
add on that, there were a lot of questions asking, is there any dye to make the nerves visible? So the best and easiest way to do is just hydrodissect them. You can use even drug itself. Once the drug gets in, the nerves start shining. That itself is it's actually a good point by Anil.
Yeah.
Yeah, that fluoroscopy is only for the academic purpose, not for the routine use. That is only for the academic
Study
purpose. The fluid, study purpose. That is only fluoroscopy. Now there is nothing.
Yeah, I think Jairam sir is now audible. Sir, you can please give your comment.
Right. Yeah, I just want to know whether if patient objects to do the procedure, can we go ahead along with the procedure, or will the patient sue us according to the law?
Good question, sir. What we ideally do is, yes, we do sometimes face these issues. What we try to convince them is it is much safer because they're worried. They must have got hear and say where they would have heard that, okay, once the nerve is damaged and it's going to leave a permanent damage. Yes, it can happen. I'm not saying no. But then we spend some time on influencing them to agree for a procedure. And more so when we are dealing with very high risk cases, when ejection fractions are about 20% or 30%, yes, we definitely convince them, we tell the advantages of them, and then we give them assurance that nothing of that sort will happen, and you'll be pain free. Polypharmacy can be avoided, and they get convinced. Majority of the times they get convinced, but there are a certain group of people, patients, where very difficult to convince them.
Thank you.
Dr. Azam, there are two more questions. One from Sudesh regarding your opinion on costoclavicular versus supraaxillary block.
Yes, we have tried supraaxillary, but what happens is, again, supraaxillary is at a very higher in the axilla. Sometimes we will be missing some, sparing some nerves. So what I have seen is a couple of times, if we are not careful in finding out the nerves, particularly when you are giving an axillary. Let me give an example. Axillary, MRU, Mr. U, M median, U, MR radial, and ulnar. That is how I remember in this fashion, MRU. So what happens is when you're in the axilla, they are very closely arranged. When you get little, distal to the axilla, suddenly the ulnar gets, deviated, and you may not be able to operation on ultrasound. Sometimes we miss this, and it has happened. So I would suggest, yes, fine if you can spend, but it takes little time to do supra axillary block. That's a very good question, Sudesh. We need to spend some time. Yes, it's possible. We can do that. And the best part is axillary block, particularly in patients who are COVID, who have respiratory distress, the phrenic nerve block is 0% with the axillary block. But costoclavicular is 5%. Supraclavicular nerve block is about 40 to 60%, and almost 99 to 100% in interscalene, the phrenic nerve palsy.
Just to add into that, when we are planning to give a supraaxillary nerve block, the angle of needle insertion and finding the needle and the visualization will be very difficult, especially when we have a patient who is quite obese. So with respect to the block performance and the technique, it will be more easier to do a costoclavicular nerve block rather than trying to do a supraaxillary nerve block.
And what I also do is a couple of things, particularly when you're doing a supraclavicular, rather, we keep the pillow at the edge. We don't let the pillow come this side if I'm using this side of the block, so that we get some space to manipulate the needle. I always bend the needle, so that gives some amount of leverage for manipulating the needle.
Okay, there is one more specific question to your case from Dr. Kalpana, I think. Can you please elaborate on anticoagulants, antithrombotics used in your case, because it is acute limb ischemia, and guidelines you followed before catheter insertion?
Yes. So we, Dr. Kopod, Dr. Sudhakar sir also is here.
I'll take the other senior person's comments
And
later.
what we have done all these years is we have used, though the guidelines goes against it, we do use ultrasound guided nerve blocks in patients who are anticoagulant. We are very, very careful. We make sure that we always look for the Doppler and switch on the Doppler and look for the vascularity surrounding the nerves. We never ever go close to that. Otherwise, yes, we have used, and this patient was on long-term Clexane, about 60 mg, but we have used in patients who are on thrombotics. There is no, even we have used in patients with warfarin. I'm sure, Dr. Sir, if I request Sudhakar sir to come in.
Shilpa, can you unmute Sudhakar Kupat sir?
Yeah, as a technique, if you do ultrasound, you can use it. But as for the complication, any complication arises, this is a medical legally, and it may be difficult to
Yes, sir.
accept.
Yes,
That
sir.
is the only thing. Unless that is only the medical legal purpose, and the possibility of anyhow that is already thrombotic thrombosis, and already patient is going for amputation. I think this patient is already a known case of a thrombotic already. You are waiting for the demarcation for the amputation. For that only, for pain only, you are giving this block.
Yes, sir.
That may be the reason you have chosen it. But sometimes, if it is a borderline case, if something, the salvage of the limb is the most important, at the time you should take care of giving it. It may cause some hematoma. That also it cause somewhat the vessel may cause upper level, not the thrombosis may be below. It may cause where you are giving a drug that may cause some bleeding occurs. The vessel integrity will come down. That means flow will be come down due to the some hematoma causes pressing the where the site of our injection. That should be taken. Think of who is performing the block should be experienced hand, but evidence wise and the practicality wise, okay, we are doing it. But for the medical legal purpose, we should not. As for the postgraduates, we should not say I can do it. I cannot. As for the experienced people, you are doing it. But any postgraduates, you should not say. You should say it is a contraindicated. You should not use it. This is my opinion.
Good evening, everyone. To add to what Dr. Kuchil Babu said, current ASRA guidelines, as far as peripheral nerve blocks are concerned, the consensus which happened somewhere in 2018, as far as superficial peripheral blocks are concerned, there are no contraindications at all. When it comes to deep, either peripheral nerve blocks or plexus blocks, there's a definite contraindication. But however, when we say superficial, again questions arise, which are classed as superficial, which are deep. In this case, infraclavicular brachial plexus block definitely falls into deep brachial plexus block, and definitely it is a contraindication. But however, ASRA guidelines are not a rule book. They are guidelines. Eventually, it is very relevant for us to weigh the risk and reward based on the clinical status of that particular patient. Here was a patient with a multiple comorbidities, with a very poor ejection fraction. If we do not, we know and we weigh the choice between the brachial plexus block or the general anesthetics. So keeping in mind the risk reward, definitely we do choose regional anesthetics in this.
Sure. Yeah, one more. I want to add on one more point. Not only the stopping of the anticoagulants itself is dangerous for the patient. The patient is a COVID patient. There is a not only one limb, we are salvaging of the limb or some problem, but other sites of thrombosis. If you stop the antithrombotic drug, it may cause a thrombotic other limbs also there is a possibility, or it may be due to the low ejection fraction. There's a embolic manifestation may occur. That's why you should be very, very careful. What you told is very, very important. That should be weight depending upon the patient. You should be most important, not to individualize the treatment. That is what you mentioned. It's a very, very should be acceptable, should be learned from the postgraduates. Individualize your technique and the complications and contraindications. Thank you, sir. Thank you.
Yeah, thank you,
Sudhakar,
sir.
Thank you, Kopat sir. Nice to
Thank
see
you,
you after
sir.
a long time.
It's good seeing you, everyone, sir. Yeah.
Dr. Azam, there are two more questions, I think. We'll
Sure,
take that. What are the chances of failure of block or sparing in CCB, supraaxillary, and supraclavicular?
Yeah. So I feel supraclavicular is little difficult, but definitely if you're used to it, if you can spend some time, yes, we can do it. And supraclavicular, though, one of the easiest ways. There, I think hardly anybody fails. And costoclavicular doesn't fail. That is my perception. We have seen, we have done quite a bit, and till date we haven't failed in costoclavicular. And the worst thing is, the thinner the patient, more difficult it is. So we need to have a little well-built patient.
Okay. I think Dr. Dilip has made a comment or question. Is this a good alternative to supraclavicular block in terms of ultrasound visualization and complications for all distal arm and forearm surgeries?
Yeah, my
Yes.
still favorite is supraclavicular. Given a chance, I just love to use supraclavicular because the way it works, the way I think we are being exposed to that number of blocks, I mean, it's tremendous because we have a very good, hand surgeon, which does good numbers. And the question was, is good alternative? Yeah, you can choose, yes. If you compare the failure rate between the supraclavicular and the costoclavicular, yes, it is almost the same because I don't see why one should fail in costoclavicular, but with good amount of experience.
Yeah, I think Harsu sir is there. Harsu sir can be unmuted and we can take his comments on both the topics if he's there. Shilpa, can you unmute Harsu sir? Yeah. Sir, you can unmute yourself.
Yeah. Good evening, everybody. I think.
Sir, good evening, sir. Good evening, sir. Sir.
Good evening, sir. Pichal Babu, sir. And nice seeing Dr. Sudhakar also after a bit of a time. Good evening, one and all. I just followed both the talks. That was an excellent presentation, both by Dr. Jagdish and Dr. Azam. What I felt was this topic should give one very, very clear message to our youngsters, beginners, especially those who are learning, that the failures of the block may not always be because of the wrong technique, but it can be because of the variation, the altered anatomy or variations in the nerve locations. So that message we should try to drive home for the youngsters. Otherwise, they may tend to get disheartened. Though I did an excellent job, I could visualize the nerve still in the block did not work. Jagdish, I suppose you agree with this particular.
Definitely.
Yeah. And second point, yeah, Azam was again and again stressing. Go into the sono anatomy. The first and foremost is, yes, our normal anatomy, we must have a thorough knowledge what it is. Only then can we, because see, it is after all, ultimately it is interpretation. It is, there is only black and there is white. That's all, nothing else. Of course, if you add a Doppler, you can see the color. Other than that, everything is black and white. So you should have some mental picture as to how the course of nerves are and where the vessels are running. So therefore, the anatomy, a sound knowledge of the anatomy is very, very essential before we take up this. I think Azam has emphasized on that, and I fully agree with that. And only one point, a little, I was also confused. Of course, Sudhakar is trying to clarify with regard to the ISAKA guidelines. What we feel is, yes, superficial block and deep block, there may not be any clear-cut distinction. But when a patient is on anticoagulants, anything that we try to do in a closed space, so that may be more dangerous when compared to these superficial blocks, because even if there is a error, sometimes it is, of course, we do take all precautions during the ultrasound. Even if there is an error and a small hematoma, still it can be a salvageable or it can be corrected when compared to the things like epidural space and all, where the things may be very, very difficult. So therefore, like what Azam said, even we practice that even when the patients are on anticoagulant therapy, depending on the risk-benefit ratio, we calculate and do go for regional blocks. I fully agree with him. I don't know how many of us, our colleagues are not agreeing with me, but then this is my view. I think other than that, it's a good program. I thank Dr. Vijayanand and Sri Ganesh for continuing this during this COVID. I think slowly we are forgetting the COVID and getting back into our clinical work once again. Hopefully, Kuchal Babu is also back into the clinical work, or you are still only taking care of thing. I don't know. It's a good refresher for all of us. Thank you very much, Sri Ganesh.
Thank you, sir.
Thank you, sir.
Gurudev, sir, I think you were valid inputs for the second talk.
One question from my side to Azam, because you had placed a catheter. So how long he used this catheter?
Sir, usually about 4 to 5 days, not more than that.
No, for this patient, I was asking you.
Yeah, sir, this was one patient who was so much of pain. Whenever we give her block, she used to literally fall to her feet and she used to thank us for, giving us pain. Whenever I said we should remove the catheter, she was very against that. And she was one patient who said, very educated Kerala family. And they said, no, I want this catheter till I get discharged. But then we had to forcefully tell her that we are already up by 5 days. And not a leak, no catheter displacement. The drug went in very smoothly. About 5 to 7 mils was the drug injected. And we removed at the end of 5th day.
No, you said that you had already placed a catheter in the supraclavicular area before. When she had first got admitted, and it came out. That's what. So, yes, is there any stabilization of the better stabilization of the catheter with this particular technique? What
yes,
just now described?
There are a lot of things or different ways of securing the catheter has been tried. What we do is we tunnel. We're using an epidural Tohi needle. We tunnel with the skin so that it holds. We did that with the supraclavicular, but it did not hold. But at the same time, the same technique, the costoclavicular held it very well. In fact, the lateral sagittal infraclavicular space also holds a catheter very well in place. Only problem is does not spread very beautifully. That's the only problem, and that's the reason why we have secondary failure. But that is one way. Second, people take a knot, take a stitch with the catheter, they circle it and take a stitch. The third, they use a tight tegatum, which we have also been using for the supraclavicular. But for some reason, particularly if patient is very thin, the catheter by the end of the day, it just comes out. Because I think whether it's pressure of the drug that goes in, various reasons. These are the few things which I have.
Yeah. So another advantage of, I think, the placement of the catheter is, the wound healing will be better because, you are continuously dilating the vessels there. Better local PaO2 will be much higher. So yes, especially, in ischemic limb. So that will definitely help. And another probably is prevention of phantom limb problem later.
Yes, sir.
Especially in all amputations, that is one of the problems. So when you keep a catheter for at least 4 to 5 days, continuously keep either infusing or intermittent boluses of local anesthetics, definitely these secondary sensitization will come down, and probably the phantom limb pain also will come down. So overall, very good, talk by both Dr. Jagdish and Dr. Azam. So thank you.
There are a lot of appreciative comments in the chat box as well. Yeah. Any concluding remarks from Kuchal Babu sir and Jairam sir, and then I'll come to Azam.
Thank you very much, sir. There's a wonderful talk given by both of the speakers, and they are very experienced, not only theoretical, they have a practical experience. That is the most important for the audience. The practical experience, what are the tips are given, very, very important. Both the speakers, the Jagdish and Azam, they give a very good tips for the postgraduates. Wonderful talk given by the both speakers, and I am very happy to be a chairperson. I invited by Dr. Balabhaskar and Dr. Ganesh and Dr. Vijayanand. Thank you very much for inviting me for this wonderful evening. I congratulate and thank you all for the ISAKA.
Thank you, sir. You enriched the program with your presence and your valuable inputs.
I would like to
sir,
thank you very much. Jain Hospital, I know for the last 20-25 years, I had one of my friends was working, and they were very excellent, and they were working round the clock in operation theater. And that was a good talk, very good talk for all of us, including us also, seniors. Even though I don't practice nowadays, I join the meeting only and speak. So nice. Thank you very much again.
Yeah, I will take comments from Azam and then I'll come to Balbasa, sir. Yeah, Dr. Azam.
Shrikant, just a small word to our postgraduates, because they are the future now, and we need somebody like Gurudat sir, Bala Bhaskar sir to anesthetize in future. Now, what my this is in my personal view, I may be wrong. What I tell the postgraduate is to anticipate things that can happen. See, we are we are not, what I should say, we are not flawless like Gurudat sir or Balabhaskar sir, where we don't make mistakes. Gurudat sir and Balabhaskar sir are, pioneers. They know everything. I mean, literally everything. But that's not the same with us. What I would suggest is anticipating a situation. For that is what I tell my postgraduate. Everybody does anesthesia. Everyone passes. There is no point in doing a CPR after a cardiac arrest that even the final year MBBS student will do. But anticipating, Jagdish will understand, on many occasions, I'm not exaggerating, on many occasions we have preempted or guessed that this, for some reason, this patient will have a cardiac arrest, and we have acted much before that. Yes, patient had a cardiac arrest, but we were able to revive. We did not waste time. So anticipating things, trying to anticipate what complications can happen if I do this or if I do that, and thinking it a little future, for their own benefits. Yes, we will pass the exams, but at the end of the day, it is you need to be different anesthesiologists as compared to others. So that was the only message that I wanted to pass, Sri Ganesh. Thanks.
Thank you, Dr. Azam. Dr. Jagdish?
As Sir rightly said, when there are so many seniors constantly looking for an updation of knowledge, I know youngsters like me stand way, way, way far behind. That as we grow older, that we need to know and keep constantly updating ourselves with the same amount of enthusiasm what I see our seniors doing. So one thing is that, sir. Second thing, I constantly tell all the postgraduates in my institute, and I would like to reiterate over here, please don't think your block doesn't work, and never believe your surgeon telling your block doesn't work. Your block really works well, provided you know how to do it. Please use ultrasound whenever possible, and please feel free to contact our hospital if you want. Any of them want to do a observership for a few days to see what is going on a live thing, and including when Sir was speaking regarding anticoagulants, we have a very good vascular department. Most of our patients are anticoagulated, and including today, we had to do a patient for ebony amputation, where we had to give a lumbar plexus block due to various reasons, though he was anticoagulated. And just now I received a phone call telling that his hemoglobin is fine. So these are the few things that we have a database, and as we go older and we gather knowledge, that we can disperse it to the future generation, as Azam sir was correctly pointing out. I would like to thank all of you for giving us this opportunity, and many more to come in future, sir. Thank you.
Thank you.
Thank you very much.
Yeah, Balbasa, sir.
Yeah, thank you. The last few minutes of words of wisdom, actually, from the seniors, they are very important, because it's like we have graduated from landmark-based approach to using a nerve locator to a ultrasound-based technique. And just like when we comment on surgeons, we comment that they come straight away, they start doing laparoscopies before doing the basic open procedure. So I would still want our PGs to understand the basics of anatomy, the basic landmarks, as Dr. Kuchela Babu sir was suggesting. We must not forget the landmarks. Straight away, keeping a ultrasound probe, telling that this is this is the nerve, this is the vessel, this is the pleura. So that should not be the case. So we should be going as per the basic anatomy, then the landmark, and of course, I don't say we should be promoting nerve locator per se, but as long as if ultrasound is not available, that's one of the options, safer options. And yes, we had Kuchela Babu sir giving his opinion and suggestions, and Dr. Jairam Pai, Rai sir, thank you very much. And Dr.
Thank you, sir. Thank you.
I thought sir joined a little bit late, but again he shared his experiences. And Dr. Sudhakar Koppar, among the senior regional anesthesia practitioners in our state, he was also very much, he passed on very nice information on the efficiency of regional anesthesia in these times. And of course, Dr. Gurudat sir kept the speakers on tenterhooks with a lot of important questions there. Thank you very much, sir. And Dr. Vijayan, President, Dr. Shimar Kamba, Vice President, Dr. K. Ganesh, and all the senior participants from ISAKA. Thank you very much. And Dr. Azam and Dr. Jagdish, thank you once again. Long live
Thank you.
Thank you, Dr. Balavaskar. I just would like to support you that to be a good anesthetist, one should know anatomy, physiology, pathology, pharmacology, medicine, and then various fields of anesthesiology. This is very important, one should think. And they have to read and know what the surgeons are doing, what are they operating, how are they doing. All these are important for us because ultimately we are the responsible persons at the end of the surgery. Thank you.
Yeah, thank you, sir. I think it's 8:44 now, but it was worth the time spent. Excellent discussions, excellent presentation with good images and videos. I think we have come to the end of this program. I request our President Vijayanand sir to please make the concluding remarks and then we'll close. Vijayanand sir.
Ganesh, Dr. Arsur sir is there.
Yeah, he spoke, sir.
Amrish is there. Dr. Amrish has come back to India.
Yeah, Amrish sir has come back. Can you unmute Amrish sir if he's there still?
Amrish sir is there.
Yeah, I saw his name. Amrish Merpadi. Can you unmute Shilpa?
He has joined Rajarajeshwari Bangalore, sir.
Oh,
sorry. Sir.
We should have.
Amrish sir, are you there, sir?
Okay. He's heading the emergency medicine department in Rajarajeshwari Medical College now.
Is it, sir?
Last about 1.5 months.
Okay.
So during
Shilpa,
COVID,
can you unmute Amrish sir?
Yeah, sir. I sent a request. Made him.
Okay.
so probably due to COVID, we never had any proper information
Message exchanges at last.
between.
Yeah, unfortunately, last month we could not do because of increased number of cases and the presenters were also stuck with heavy COVID duty. So,
Yeah.
But we'll henceforth, I think now it is time to continue.
Yeah.
Amrish sir, if you can hear us, you can unmute yourself, sir. Okay. It's good to see him after a long time. Yeah. Vijayan sir, you can, I think we'll take his comments if he's available.
Yeah. Shall I conclude?
Yeah, please, sir. I think he has not heard us or. Yeah, go ahead, sir. Vijayan sir.
Yeah, respected teachers, senior office bearers, past president Dr. Arsur sir, Dr. Balabhaskar sir, Dr. Gurudat sir, Dr. Jairam Rai. Very happy to see you after a long time, sir. And Kuchala Babu sir was very nice to see him after a long time. He was our president national in the Mysore Bangalore National Conference. I thank Azam and Jagdish for excellent presentation. It was a very nice presentation. Many are appreciated in the chat box, and it is very nice to see. Thank you, Azam. Thank you, Jagdish. And I thank Dr. Gurudat sir and Dr. Balabhaskar sir. Especially Balabhaskar sir made this occasion because last time we had missed it. Sumagra was supported because of the case load, they can do it. And I thank Dr. Balabhaskar sir for this. Ganesh and Dr. Kumar sir, thank you. And all the office bearers and all the attendants for this 10th education program of the Karnataka ISA. I thank you for joining this. Thank you very much.
Thank you, sir. Vijayanand, you are in your new avatar. Nice to see you. Yeah. And before I conclude, we'll have our next month program conducted by Team Shimoga. So that will be again on the second Thursday of July. So please do join us at the same time next month. We'll close this session, and I thank once again everyone, both the speakers, Dr. Azam.
Do you want to announce the winners of the quiz?
Okay, that was announced in the chat box. I'll read it out again then for the benefit.
You
For
can
the
read
first,
out and
yeah, I have already communicated to them to contact me on isakanadaka@gmail.com to receive the certificates. The winners of the first topic were Dr. Soundarya and Dr. Sandeep Gaud. The first question nobody answered, maybe because the chat was disabled at that time. And for Dr. Azam's talk, the winners are Dr. Harsha D and Dr. Anusha Hiremat. So they can please send a mail to isakanadaka@gmail.com and I will send the certificates to them. Congratulations to the winners. And thank you everyone, including the speaker, the chairpersons, and yeah, Vijayan sir, you want to say something?
Announce they can send articles to Karnataka Anesthesia.
Yeah, I request everyone, our editor-in-chief, Dr. Sudesh is here.
Requesting them to send articles to the Karnataka Anesthesia Journal.
Yeah. So I request everyone, especially the postgraduates, please consider Karnataka Anesthesia Journal when you submit your articles. Dr. Sudesh is there. You want to make appeal, Sudesh? Can Sudesh be unmuted?
Sir, anyway, you're requesting. Anyway, on my behalf, our president and secretary sir are requesting. So I will also. The thing is, I'm already ready with the next issue. Another two issues I'm already getting ready. One issue is almost on the preprint phase. So a few more articles. I think I'll be able to clear the backlog till October 2021. Sure.
Dr. Azam has already assured you one article, I think, in the chat box.
Yes, sir. So that's the reason why, because if we can try and somehow get that backlog cleared, the next moment I'll be going ahead with this one, sir. This one, indexing process. So once indexing is done, it becomes retrospectively applicable for all the articles. So right from the earlier issues. So that is why I'm a little pushing forward to get as many articles as possible. Already we have completed 2019, almost I am done with. So I'll be starting with 2020 issues now onwards. Already there's some 3 or 4 articles I've got for 2020 issues, but I require some more. Few of the review articles have been promised by various members of our executive committee. I want few more articles in the form of clinical investigations and letters to editor and
Dr. Sudesh, a lot of senior people are there. Arsur sir is there, Gurudat sir is there, all HODs are there. So I'm sure.
Yes, sir.
They will help
you. I am happy. I'm lucky enough that every corner of Karnataka is contributing in some or the other way, but just it needs a little more push, sir. That's why.
Yeah,
Gurudat sir,
many HODs here. Yeah, Dr. Anand Mangera is there, Dr. Radesh Hegde is there. Even one article from each college is, I think.
Each college one article that will surely push my. In fact, I can publish more and more issues, sir. I can, in fact, I can publish all four issues in a year instead of 2 issues. So that will be a good thing, sir. So, and that actually matters a lot when we go for indexing, sir. So that's why I request a humble request to all the respective HODs of the institute here and the senior, my senior contemporaries in this. So to kindly submit articles to Karnataka Anesthesia Journal. As of now, the waiting time is less than 10 days from submission to processing. So
good. That is a very short time.
I have sent a letter to all the HODs to encourage our Karnataka Journal.
Thank you, sir. The other day you spoke to me, sir. You told me that you will be doing that. Thank you very much, sir.
So people are ready to send it also, because this will be the first state to have it, because we have a prestige of having 2 national editors.
Who are sir? 3, sir. Dr. Kotu, Dr. Harsu, Dr. Bharwar,
sir. I'm sorry. So we can have a quality journal of our own state.
Yes, sir. That's sir. Yeah, that's our idea, sir. We'll have to have a standout journal among all the southern states.
Thank you.
Everyone for your support. Yes, sir. Please, sir. Jairam, sir. Please, sir.
Just send me a message in future for I'll join the webinar.
Sure, sir.
Sure,
sir. Nice of you, sir.
Sir, it will be in the district wise, sir. Please, we have a website for a WhatsApp group in every district also. Jairam, sir.
No, he may not be there in the group, I think. That's why he's not receiving.
We'll add in that, sir. We'll add in that.
Okay. Thank you.
Thank you, everyone. Thank you, Dr. Az. Yes, sir. Vijan, sir.
Udupi is slightly lagging behind. Mangalore is doing well. I've asked Bandari and all the people, sir, also. Now they have started their branch. They have a president, the secretary, everything. Now they are doing well. I'll speak to them to add up also the
Okay.
Udupi guy.
Yeah, no problem. I'll find out from Shema, KSEC Medical Academy,
Yes.
where I worked
Yes,
as a
yes.
professor
Yes,
for
yes.
Sure.
20
Anand is
years.
there.
Okay,
Srinath is there, sir.
Thank you.
We'll send you, sir. We'll send.
Thank you.
Yeah. Thank you, Dr. Azam, Dr. Jagdish, Dr. Jairam, sir, and Dr. Kuchila Babu, sir, for your gracious presence and active participation and excellent topics.
Thank you.
Presentation.
Thank you, Dr.
And
Manish.
all the participants, you are very active, dynamic. We had a good discussion actually. The first presentation itself went on for a long time because of the active engagement of the audience. I think that is excellent for us as a education providers for practitioners and postgraduates. Thank you. We come to the close with this. See you again next month on the second Thursday at the same time at 6:30 with the new
Last
topic.
statement, Shri Ganesh.
Yeah, Balwas sir, please sir.
Statement is, it was very nice. I mean, very important point raised by Dr. Vijayanan. So if we get an indexing, no, it will be the first state journal.
Yes, sir.
That honor will go to Karnataka only. So let us all support Sudesh and see
Yes,
that our
yes.
journal gets to be the first state anesthesia journal to be indexed. That's
Yes.
a great point, and we have to do that and celebrate also later.
Yes, sir. Sure, sir. Sure.
Okay.
Thank you, everyone, and good night.
Good night.
Thank you. Good night.
Shilpa, we
Thank
can
you.
close the session. Yeah.
Good night.
Thank you, Shilpa.
Thank you, Ganesh.
Yeah, thank you, sir.